And a lot of times that's easier said than done. I don't sit here with all the answers on how to do it. But if I know that issues are being resolved or being worked on at the very least, I'm much more likely to participate. And so don't leave it to one area or one or two departments to battle it out. Because at the end of the day, you don't really get anywhere with that. You got to have a hospital-wide or a system-wide approach that, if you're in a system and you discover something, did you share it with the other systems, the other hospitals within that system? Maybe your other outpatient facility, associated with it. What is your dissemination of what you learned look like? So to start implementing it and to get that buy-in, it's definitely not an overnight thing. It is not a flip a switch and we're going to have this and we're going to have it in place and it's going to be successful. It is a work. It is arduous. Not always a whole lot of fun, but as you get things going and you see successes, then you really start to go, okay, this is good. I have an issue that I have been encountering for 6 months or a year. I've just never said anything because we all deal with the same issue. Let me bring it to the table. And so you start to get those things that come forward, and that's when you truly start to prevent errors.
Now, within the regard to just culture, I've seen a lot of physicians and a lot of nurses specifically who are a bit worried about the outcome of this trial, the verdict that was given. It strikes a lot of fear into the healthcare professionals and losing their license that they've worked so hard to earn. So is just culture going to be realistic? Is this something that is it going to be damaged by this verdict?
From my perspective of, reading the trial, reading the history, is that there were a lot of other errors and not open communication. I'm not trying to put anybody under the bus, but there's a lot of pieces to this trial and to what happened right after the incident and what did not happen. And I think that is really important for healthcare professionals to remember and to realize, because there's a systems responsibility also. And that has to be taken into account.
So we know that this error was not purposeful. We know it was brought to a criminal court. What repercussions do you think we're going to see in healthcare? Is there going to be that anticipated downhill effect in healthcare?
I know in my own institution, the day the verdict came down, we received an email from the CEO of our healthcare system stating that our hospital system believes in a just culture, believes in these errors, will support the healthcare professionals that are making incident reports, and to remember that there was a lot of other details of the trial and really support it. And it came from literally our CEO, our chief executive nursing officer, our chief of quality and safety. So it came from a number of people at very high levels. And were repeated emails for about a month. James, I don't know if you want to speak to it from a leadership perspective.
It's really hard to answer that question in light of everything that's going on in healthcare today. And I don't know if that's a cop-out. I think people could use that answer at any time in history in healthcare. But if you take a look at, there's a national nursing shortage. We're in the middle of a pandemic. hospital expenses are going up. Patients are staying in the hospital longer due to certain diseases, COVID being one. So revenue is going down. It's making it more difficult to manage hospitals and hospital systems. The federal government has not awarded any relief here recently pursuant to COVID. So you have all of these factors coming into play, and that's affecting your workforce, affecting the current situations in management. And so it's very difficult to answer. I will tell you that what I'll say is future nurses first versus current nurses. Future nurses, I've been on the recruiting trail. And most of the future nurses that are in school now, they're aware of the case, but they're not dropping out of school just because of that case. Okay. You don't hear it in the news advertised, it's not very prolific out there unless you look for it. So I'm not sure from a nursing standpoint, is it going to drive away future potential nurses? I don't know that. I don't have that answer yet. I lean towards no right now. What I can tell you is that from a being a leader in an emergency department where time is of the essence quite often, it has had an impact. This verdict has slowed down care. Nurses who normally had a practice of just running and going and doing and doing certain things now will wait for the physician to put a medication order in. Will now wait after the physician puts the order in, wait for pharmacy to approve it and flip it over to the MAR before giving that medication. Now, it's pharmacy, let's say they staff 5 pharmacists through the day just to approve those medications, and one called in sick. So what is the delay there now before we get our emergent medicines to our patients? So I could tell you there is a frontline delay while we are seeing more and more patients coming into emergency departments because fewer are getting primary care, preventative care. And so as that number rises and as our approach to patient care goes down, has to slow down, it's not difficult to see down the road there's going to be issues with waiting, patients getting worse before they're seen. So from active staff, it definitely is impactful. Future staff, future students, they quote unquote haven't been in the real world yet, so I don't think it's as impactful for them.
Jake, from that director perspective, you're talking about delay in patient care, which I think it's great that, we're probably getting back to the way we always should have done it, back to those double checks, those triple checks to make sure what we're doing is correct. So my question, though, is more along the lines of that frontline delay, the decrease in customer satisfaction and how quick it is for them to get, say, their pain medicine or for the physician to come in and do a procedure. So how is that going to affect those HCAHPS scores and some of those different scoring mechanisms that are used, or matrices rather, that affect, say, hospital pay?
It's going to be huge. And it's going to be difficult to weed that out and actually put a number to that and say that, hey, this is the cause. But from an ED perspective, you're going to see higher wait times. Patient satisfaction. We have all these very in-depth research that's done. But from an ED, I can tell you it is directly correlated to how long you got to wait to be seen by a physician. We can add all these other things in there. But if you put yourself in line at Walmart, how long or which line do you go to? Do you go to the self-checkout where you can get in and get out? Or do you go behind the line to be checked out when there's 9 people in front of you? No one likes to wait. It's human nature. No one likes to wait. So it's the same thing in ED. You'll have more left without being seen, meaning they left, they didn't get care there. So what does that mean for our hospital system as far as their liability? HCAHPS, patient satisfaction is going to go down. It is there's just negative effects all around. You look at it now, and we look at there's a national nursing shortage. Well, there's a national EMS, EMT, paramedic shortage when you look across the country. If it takes me longer to see patients within the department, my EMS crews are going to have to sit on the wall longer, which means they're not back out in the field answering your, mine, our family's 911 call. So this problem or this occurrence has affected so many things, even back out into our own homes, that people don't realize. There's just a very, very impactful nature of this verdict that is very far reaching.
And I want to touch on too, you're talking about some shortages. What about those OBs and pediatricians that we have national shortages on as well? And don't they have I don't know the official word for it, but I know, for example, for children, for OBs, they can be sued up until the child is 18. Is that true? Is that something they need to be worried about?
It's really interesting for what OBs and pediatricians earn as income. They pay an unbelievable amount in insurance premiums. If folks actually knew how much they paid, I think they would be shocked, and they wouldn't be so upset about paying office copay. They really put themselves on the line, and you got to think there's a reason for this shortage. And so it really is going to the problem with both or any line of medical field or medical specialty when there's a shortage is the demands on that individual's time goes up. The demands for what they need to do go up. So the more things you do in a shorter amount of time, there is a higher probability of error, which means in our short staffing state across the country, now is the time that we need to adjust culture to address these issues that are coming up that may not have come up 5 years ago, 10 years ago, when we weren't under such a shortage of staffing. Because these are all new issues, new concerns. So now more than ever, while we have shortages, it's more imperative to actually institute a just culture to address it.
And I will agree with James. As I said, my background's in pediatrics. For years, I did pediatric critical care, and now I'm in a subspecialty. And my peers, my physician colleagues have paid more money. And I know as a nurse, my malpractice insurance, and as an NP, my malpractice insurance is higher. I think the more concerning is OB. The number of nurse practitioners, physicians, midwives that are no longer actually doing deliveries is very impactful. And, given the shortages we have now, post-COVID, or really, I don't think we're post-COVID, but it has been quite difficult, as James has said.
Absolutely. And one of the things that you were hitting on, Jay, was about the multiple tasks that are being placed on the shoulders of healthcare professionals now. And I really want to take this back to nurses for a minute, because it seems as though nurses are we're the only healthcare profession in clinical practice where we are given multiple tasks that many times cross over to what other professions typically do. For example, respiratory therapy is not available. Well, who's going to give the breathing treatment? It's going to be the nurse, right? If physical therapy is not available or housekeeping is not available, typically you're going to see the nurse performing those functions on top of all the other roles and tasks that we are to do as a nurse. So how do we expect nurses to meet all these extra expectations and complete these tasks error-free?
That's a great question, and it's one that I have battled with for a long time. And we mentioned the shortage of nursing, but the truth is there's a shortage in all workforce. there's a shortage in trying to get patient care techs or support techs to assist nurses. You got to remember what's happened in the economy. People have left the workforce. A lot of frontline workers left for quite a long time. So recruiting them back in is very difficult because this is a difficult line of work. You mentioned some of the areas that you work on, and I thought about this recently from an emergency department perspective. My nurses are expected to turn the rooms over, so they do the EVS job. They are expected, the nurses or techs, to distribute meals, ensure everyone's fed for dietary position. You mentioned respiratory therapy with breathing treatments, what have you. Stat meds, making drips. If pharmacy hasn't gotten to it in time or isn't fast enough, it's emergent, we make our own. You look at finding certain placement for certain patients. Case management has to step, you take into a case management or social worker function. As you evaluate patients, a lot of times we enter protocols to get workup started. That is a physician or a provider responsibility that we have allowed nursing to do to expedite care. Also drawing labs and doing those things, we do the role of phlebotomy. So, you do all of these things, and quite frankly, a nurse wears so many hats that if you were to break down any given day for a nurse, and I'll pick on a med surg nurse because it's an area that I openly acknowledge I can't work in. I'm not fast enough to work there. I think it's the hardest department in a hospital. If you had 6 patients, you did an assessment on all 6 of them, 30 minutes, do an assessment, get it in the computer. That's 3 hours of your day. You've been tasked to discharge 3 of them. That's 30 minutes or more for each of those 3. You've been tasked, you've gotten 3 new patients. You've got to do an admission there. You got to do an assessment there. It's an hour plus for each one. You do a good med pass in the morning for all of your patients. By the time you start adding these hours up in the day, one, your staff hasn't had a chance to take a lunch. They haven't had a chance to use the restroom. And then they run out of time. So what gives? Is it the call light that doesn't get answered? Is that why we're seeing so many more complaints now? So we're passing all of these functions down to the bedside because, hey, it's the easiest thing to do because they're with the patients supposedly all day long. So we've got to figure out how to, and I kind of alluded to it previously, how do we take some of these hats off that create the time for nurses to focus on their patient care and allow them to prevent some of these errors? You got to give them time to prevent the errors that are happening. And so if we don't give them time from a frontline staff, don't give the frontline staff time to do their job, errors occur. What kind of message does it send when we're going to go in and discipline them for not having time to do their job and errors occur? So that's really, if you look at just culture, you learn from those errors and you put in processes to change those so that you kind of prevent the punishment and the retribution for some of those actions, which can all kind of be tied together. It's all the circles. So it's a very, very difficult concept. And nurses, quite frankly, are at the bedside and they're assigned patients. And they keep getting more and more hats to wear with no more time in the day.
The other thing, too, that is we haven't started seeing it in the hospital setting, but given the shortages, I think we will be soon, is that nurses are going to have to prioritize. If they need to give a respiratory therapy treatment, so they need to give a respiratory treatment versus walking a patient, well, that respiratory treatment's going to come first. That's
absolutely.
And then so we are going to start seeing increase in bed sores, increase in pneumococcal infections, or hospital acquired infections, because people are cutting corners because they are so stressed and so overburdened that we're going to start seeing an increase in those things that are not recoverable from a financial perspective for the hospitals. And something is going to need to be done because eventually the system may just fall apart.
Absolutely. I think that's such a great point that you brought up too, about having to choose those priorities, and what we prioritize, which would be your respiratory treatment, might not be what your higher leadership that doesn't really understand what's going on at the bedside would prioritize, because what they see is, well, now we have a injury to the patient because they have been laying on the bed or in their same position for a little bit too long, and that takes money away from the facility. So absolutely, that's a great point. We will talk more about these unintended consequences that may be seen in quality of care in episode 3, as that's unfortunately all the time we have for episode 2. In this episode, we really focus the discussion on how culture impacts a work environment and the overall quality of care patients receive. Please join us for episode 3, where we will continue our discussion of medication, dosage assessment, and medication administration from the perspective of responsibility and accountability. This is Candace Pierce with Colibri Healthcare.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.